So, Nick, next question. This is all around estrogen receptive cancers. So, whilst social media is amazing and has been great for sharing information, there still seems to be a lot of confusion out there about hormone replacement for those women who have experienced a hormone receptive cancer of one type or another. And I recognize, and I think everybody does now, that this is very much about individual consultations. However, as somebody who's been working in this area for a very long time, do you think that you could give your sort of up-to-date overview of what the current guidance is around those women who have experienced an estrogen receptive cancer but are having menopausal symptoms and are struggling with them?
I think the first thing to say is that it is a complex area, and therefore it's difficult to give clear general messages that apply to everyone. And that's where perhaps social media can raise hopes in individuals that perhaps have more complex histories than others who can have a particular treatment safely. And at the end of the day, I think what you want, what I want, is for every woman to be able to go and have that chat with her healthcare professional, be it her GP or her breast specialist or her oncologist, menopause specialist, and have some well-balanced advice taking into account the benefits and the risks in her individual case. Absolutely. And so that she can be empowered to make a fully informed choice.
100%.
And I think the first thing to say in terms of treatment options is that there is usually something that can be done for everyone. It may not be conventional hormone therapy, but there are other ways of potentially alleviating symptoms that may occur as a consequence of menopause or as a consequence of the malignancy or the treatment for the malignancy. So we can, I suppose, work our way through the more common hormone receptor positive malignancies and start with breast cancer and say that we take many factors into account in deciding whether somebody who's had breast cancer can have hormone replacement or whether they are better off having an alternative. And that will depend on the stage at which the cancer is picked up, whether it is expressing hormone receptors like estrogen receptors or not. It will depend on what type of surgery and what type of chemo and radiotherapy has been required and what type of adjuvant treatment. So the treatment after the breast cancer the main treatment has been given, like tamoxifen or like the group of drugs called the aromatase inhibitors, like letrozole, for instance.
Nick, would you be kind enough just to explain the difference between tamoxifen and the aromatase inhibitors?
Yeah, so put simply, tamoxifen blocks the estrogen receptors. So even if there is estrogen in the body, it can't trigger the receptors, and so tries to reduce the risk of recurrence of breast cancer that way. With the aromatase inhibitors, there's an enzyme called aromatase, which converts testosterone to estrogen in postmenopausal women. And so the inhibitors prevent that conversion. Right. Estrogen in postmenopausal women comes largely from conversion of testosterone and its precursors in the tissues. So it aims basically to reduce estrogen levels to virtually zero. But because it is such a profound effect, that's why women can have such severe menopause-related symptoms. And they're particularly distressed by the urogenital symptoms, the vaginal atrophy, the dryness, the pain on intercourse, etc., etc. But there are the other sort of classic menopause symptoms as well. So if I see somebody who's been diagnosed with breast cancer, I'll take all of that into consideration. I think for me, one of the most important things is quality of life. I always say longevity means very little without quality of life. But if we are to restore that quality of life, we need to try and do that in as safe a way as possible. If somebody has had a hormone receptor negative breast cancer, then giving them HRT won't increase the risks of a negative breast cancer occurring. But there is evidence that women who've had a hormone receptor negative breast cancer can then go on to develop a hormone receptor positive breast cancer, which would be affected by going on to HRT. Having said that, having very carefully weighed up the pros and cons, and prescribing, and I must emphasize this, off license or off label, we do often give HRT to women with hormone receptor negative breast cancer if they are, strongly symptomatic. If they're hormone receptor positive, then we have to be much more cautious. And that's where we really need to try and consider all the alternatives before resorting to HRT. That's not to say that HRT is off the table completely, but we do stress the importance of optimizing lifestyle, diet, exercise, getting all of that right, stress reduction, finding any trigger points for symptoms like alcohol, smoking, etc., caffeine, and then considering medications that are used normally for one indication that can be of benefit for hot flushes and sweats, like clonidine, which is for control of blood pressure, like certain antidepressants like venlafaxine, which can help with hot flushes and sweats, like oxybutynin, which we're finding out more, got a couple of randomized trials now, showing a nice benefit for hot flushes and sweats. So that oxybutynin is a drug used normally for control of bladder symptoms. And gabapentin, which is used in epilepsy and for neuropathic pain, which has been shown also to have reasonably good control for menopause symptoms, but can cause drowsiness. But if you take it at bedtime, that can help with sleep. And that's where there may be an advantage to it there. I think it's important also for your viewers to know that we're doing quite a lot of research into the NK antagonists, neurokinin receptor antagonists. So the neurokinin receptors are in the brain, in the hypothalamus. We know that the pathways that lead to hot flushes and sweats start in the hypothalamus, and basically these are substances or medications that will block those pathways. And the research thus far has been really exciting because it seems to show that treatment with NK receptor antagonists seems to be almost as effective as normal HRT for alleviating hot flushes and sweats. And at the moment, we're involved in a study. I'm a chief investigator for a trial looking at NK receptor antagonists in otherwise healthy women, but we're also going to be looking at women who have had a past history of breast cancer. So, anybody who would like to collaborate and take part in that study, we'd be happy to hear from them, and we'll put them on our database.
And where could they find those details, Nick?
Well, the details will be available on the, and I haven't got a link for you yet, but I will provide you with one.
That's all right. I can share it in the notes.
The Imperial College Healthcare Trust Women's Health Research Center website. Bit of a mouthful, but it'll be on our research webpage, and I can give you the link.
Perfect. I can share that. And Nick, those women with the estrogen receptor positive breast cancer, around, and negative for that matter, around things like the genitourinary symptoms, would you be considering the local estrogens for those or no?
Okay, so that's a very important question, and the answer is we do consider local estrogen, and now there's also a local DHEA preparation that can be used. Again, that would be off-label or off-license. It wouldn't be prescribing according to label. So if moisturizers and lubricants haven't helped particularly, or have only partially helped, then in women on tamoxifen, we have little hesitation in giving them some local estrogen because, as I explained, the estrogen receptors are usually blocked by tamoxifen. And the studies that we've had so far are reassuring, although they're mainly observational trials. If they're on aromatase inhibitors, it's a bit more tricky because it's sort of counterintuitive to give somebody estrogen when they're on a treatment that's supposed to reduce their estrogen to nothing. So that's where we need to have the conversation with the oncologists and the breast cancer specialists to say, is there an opportunity here to switch to tamoxifen? And then if that doesn't alleviate the symptoms, then give some local estrogen in combination with the tamoxifen.
Okay.
And I think that's a really important point that I'd like to illustrate, which is whatever decision we make as menopause specialists, we try and not go against the decision of the oncologist. We try and all sing from the same hymn sheet, so there isn't, sort of an argument going on, and then the poor woman is left in no man's land. She doesn't know which way to turn.
Trying to take more of a multidisciplinary.
Totally, yeah, absolutely.
Approach. Okay.
Yeah. It's not always easy, but
no, these things are not always easy, but it's good to know. It's good to know, Nick. And what about for things like the gynecological cancers? What would be the approach there? And the reason I ask is because we hear from so many women who have had particularly early stage endometrial cancer, and they've had a hysterectomy, and then sometimes as part of that, they've gone into surgical menopause because they've had an oophorectomy too. So for anybody that doesn't know, bilateral oophorectomy is having both of the ovaries removed at the same time. Could you talk about sort of the gynecological cancers and what your approach might be there? And again, I recognize that we're talking in very, very generalized terms.
We're talking in generalized terms. We're talking in an area where prescribing according to the product license, it would be off license or off label, but working from first principles and also from some clinical data as well, it looks like using hormone therapy in women with vulval cancer, vaginal cancer, cervical cancer is generally speaking safe. There are some rarer forms where the jury is out. For instance, most cervical cancer is of what we call the squamous type of cells, but there are some small subfraction, which is adeno type cells, adenocarcinoma, and in those we have to be more cautious. But for the vast majority, it looks safe to give hormone therapy, even in more advanced stages of those cancers. For endometrial cancer, so cancer of the lining of the womb, if it's early stage 1 and stage 2, where it hasn't spread significantly, and the process of treatment is essentially curative, then we feel very confident in being able to give hormone therapy if required in those instances. And the trials that have been done, which includes a randomized trial, there's some studies, observational studies, have largely been reassuring that there isn't an increased risk of recurrence. Ovarian cancer is a bit more of a controversial area. Again, we tend to give it an early stage, but we're a bit more cautious about a type of ovarian cancer called endometrioid, because this is more likely to have receptors, hormone receptors, like endometriosis, for instance, where if you gave estrogen, potentially it could cause that cancer to recur and get worse. But for the other types of ovarian cancer, the data from the Royal Marsden look quite promising, that if you give HRT over the long term, women tend to live longer lives. The disease-free interval does not seem to be shortened, if anything lengthened, but they didn't have enough cases to look at the subtypes of ovarian cancer. So where those, so now talking on an individual basis, in those individuals where perhaps their ovarian cancer was more advanced, exhibits hormone receptors, we really do have to be more cautious and think about alternatives. Where it's earlier stage, doesn't exhibit hormone receptors, we're more comfortable in giving HRT.
And again, as you said earlier, that's very much a kind of multidisciplinary conversation.
Totally, totally. We work very closely with our oncologists, our gynecologists, colleagues who do the cancer work, breast surgeons, as we said earlier, with regards to breast cancer, so that we're all singing from the same hymn sheet.
Perfect. That's really helpful. Thank you so much, Nick.
Can I just say one more thing?
Of course, please
because
do.
I've had a couple of patients come to me and say, well, surely if I use bioidentical hormones, it'll be safe as opposed to using the more traditional types of hormone therapy. No, we don't have evidence to say that one type of HRT is safer than another type of HRT in women with a past history of cancer.
Yeah.
We know from observational data, from controlled data, case control data, that some types of HRT look safer than other types of HRT as far as women who are otherwise healthy and following them up and whether they get breast cancer or not. But we cannot apply yet those principles to women who've had a past history of breast cancer. We just don't have the data.
Yeah. Okay, lovely. Thank you, Nick. Thank you for